in about the next 30 minutes, I'll focus on cancer-associated thrombosis with a particular emphasis on the issue of thromboprophylaxis, risk stratification, the available data on really the issue of thrombosis in cancer in the outpatient setting. While there's been lots of attention to sort of mandatory VTE prophylaxis on the inpatient setting in the cancer patients, and some of the registries obviously show that cancer, is a major risk factor in inpatient setting, it turns out that probably about close to 3/4 of thrombosis-associated cancer occurs in the outpatient setting. So I do have some disclosures, which I mentioned yesterday evening, but none of them are relevant to today's talk. So whenever we talk about cancer-associated VTE, we also always go back to Trousseau, who wrote back in 1865, when you are undecided about the nature of this disease of the stomach, when you hesitate among chronic gastritis, simple ulcer, and carcinoma, phlegmasia, albadolins, occurring in the leg or arm will enable you to assert positively that cancer is present. So he clearly made this association with cancer and thrombosis, and actually had the ill fortune actually to develop the complication himself. So within the big picture, it turns out if you look at all patients presenting with symptomatic venous thromboembolism, about 20% have cancer, so it's an important subset of the cancer population. We've also learned over the years that standard therapies with heparin followed by warfarin really are not as effective in the cancer population than in the non-cancer population, with an increased risk of recurrence and arguably even increased risk of bleeding. And some of these patients are the ones that, even if you manage their warfarin very well, they break through and develop recurrences on warfarin. Interestingly, also, having a symptomatic thromboembolism in the setting of an active cancer really worsens your prognosis, which I'll show in a second. And then there's just been this story, as Trousseau illustrated, that sometimes thrombosis can be the first manifestation of an underlying occult cancer. Lots of studies actually suggesting, if you have a patient who presents at an older age with an idiopathic VTE, that the cancer might be detected in up to 10% over the next 2 years. Which obviously leads to the issue of all the scanning that goes for looking for an occult cancer. And I think it is something to think about when you have a patient who presents at an older age with idiopathic VTE. But really, you shouldn't do blind CT scannings. The evidence is not there to support it. And with the current surveillance procedures in place in this country with respect to pursuing signs, symptoms, colonoscopy after 50, breast screening in women, it's not clear that there's a lot of pickup at this point if you really take a really good history and follow any things like cough, weight loss, of course. So this is one of the studies. It's actually a Danish study where they crossed registries of cancer and venous thromboembolism in Denmark, where they keep very good registries, and you can see the impact on 1-year survival of if you had cancer at the time of VTE as opposed to cancer without VTE, that their prognosis actually was about 1/3 of those who didn't have VTE, really emphasizing the point of the negative prognostic impact of having symptomatic thrombosis in the cancer population. But I think when you think about thrombosis in cancer, like we think about thrombosis in the non-cancer population, it's all about risk factors. The more risk factors you have for VTE, the more likely you are to have a clot. And of course, it becomes complicated because what type of cancer you have, what stage of cancer are relevant. The issue of pathogenesis I'll come to. Much of the focus now is on tissue factor, particularly tissue factor microparticles, mechanistically as perhaps underlying the hypercoagulable state. There have been lots of other postulated culprits. Years ago, there was a cysteine protease that was promulgated as a potential pathogenic mechanism. That really has not stood up. But remembering that cancer patients have other comorbidities, they may be at bed rest, they may have hospitalizations for intercurrent problems such as surgery, and they're older, and just age itself is a risk factor of VTE. And then some of the therapeutics we have, some of the chemotherapeutic agents, hormonal therapies such as tamoxifen, some of the biological therapies, thalidomide, lenalidomide in the myeloma setting, some of the anti-VEGF strategies, bevacizumab is associated both with more arterial as well as some perhaps slight increase in venous thromboembolism. And finally, with the improvement in therapeutics, cancer patients are living longer and more likely living longer, oftentimes, unfortunately, with active disease still, so they're more likely to potentially develop thrombosis because of the length of time that they're surviving. So, you know, the whole issue then of thromboprophylaxis in the outpatient setting, you know, has been addressed in a number of trials. There were some smaller trials done with low molecular heparins versus placebo years ago that really couldn't show an effect, but they were probably underpowered, and I don't know how well you can see this particular study. This was the first real positive study presented at a plenary session at ASH a few years ago using a low molecular heparin available in Europe, never licensed in the US, but it is a low molecular heparin prophylactic doses, nadropirin for the prevention of thromboembolism in ambulatory patients with metastatic or locally advanced solid cancers receiving chemotherapy. It was a randomized placebo-controlled double-blind study with a 2-to-1 randomization between cancer patients and placebo. And what they actually showed here was a significant reduction in symptomatic venous thromboembolism, and they also included arterial events from 3.9 to 2%. And the duration of therapy was relatively short, over about 3 or 4 months. But they did show for the first time significant reductions using a prophylactic dose of low molecular heparin. But obviously, the rates are still, even in the treated group, relatively low. Although remember, this is only over 4 months during the initiation of a chemotherapeutic regimen in people with advanced disease. So if you were to annualize that, assuming the risks remain linear, you're talking about a more substantial rate of probably closer to 12%. But nevertheless, this was the first positive trial, not something that in any way changed practice. And that was really followed up then by an enormous trial, actually done with an ultra low molecular heparin, which is not on the market. It was a trial that was organized and sponsored by Sanofi, an international randomized placebo-controlled phase 3 study with 3,200 patients where they took this ultra low molecular heparin, cimeloparin, which has even a higher anti-10A to anti-2A activity than enoxaparin or dalteparin, which range somewhere between 1.8 to 4 to 1. This is like 30 to 1, more like fondaparinux, which is all anti-10A activity, and randomized either to a daily dose of this preparation or placebo for at least 3 months or until there was a change in chemotherapy. Their primary endpoints were symptomatic VT, non-fatal P, or VT-related death. You can see the inclusions, number of different solid tumors and metastatic disease, and they excluded people who had very short life expectancy, impaired renal function, or very poor performance status, 3 or greater. And indeed, this trial, too, was positive in terms of a benefit, in terms of the endpoints of symptomatic VTE. The cimeloparin group, you could see, had a rate a little under 2%, and the placebo group was about 4% there. Now, this trial, they did do some subset analysis and could stratify by some criteria I'll come to, but this actually went to ODAC, and ODAC gave it a resounding 14-to-1 rejection of approval. Basically, it wasn't clear exactly which populations would really benefit by this. And again, I think the problem we have here clearly is the events rates are relatively low in unselected patients. Adding, some standard tests we might have available, the D-dimer are not completely specific, although there's a case that could be made. Things like D-dimer might have some adjunctive value coupled with other parameters. And finally, we need better predictive markers of who's really at risk. So a person who's done very important work in this field is Alok Khurana from Rochester, who's now at the Cleveland Clinic, who teamed with people at Rochester and Gary Lyman at Duke to really prospectively look at clinical risk factors potentially as predictors of thrombosis risk. I remember I actually heard Alok first at a thrombosis meeting where he presented some of his data, and this actually came out of a large febrile neutropenia database that was followed, and he actually put forth the idea that high platelet count was a biomarker, but he actually, in looking at this very large database, looked at parameters they had available, and you can see some of the ones: types of tumor, stomach, pancreas, higher risk, lower risk, types of cancer, hemoglobin, less than 10, I think that says, if I can read it, high platelet count, white count even, greater than 11,000, and finally body mass index. And putting all this together and looking in this database for patients who actually develop thromboembolism, he could come up with a risk score, which has been termed the Khurana score, and you can see the number of points you score based on type of tumor: 2 points, stomach, pancreas, high. Interesting, lymphoma gives you 1 point in this scoring system. Gynecological GU tumors, excluding prostate, which are lower risk. And you can see the other parameters which give you 1 point. And then using this score in the development cohort and subsequently in a validation cohort, he could actually not only derive this thing, but prospectively show that it had predictive value when it was looked at prospectively. And you can see how, depending on the risk category score in terms of number of points, just using these parameters, he could stratify people into a lower risk group, an intermediate risk, and a high risk group, where you're getting up now to about a 7% rate of thromboembolism in the cohort. And actually, this was independently validated by a group in Austria in their cancer cohort. But still, you know, the rates, while they're getting up in the higher group, hasn't yet implied that that group should be candidates for thromboprophylaxis. Well, this is way too confusing. I think that actually comes from a publication for Fred Rickles. In terms of all the different potential mechanisms by which cancer might induce a hypercoagulable state, and I'm not going to go through it. There are many hypotheses, many different mechanisms relating to potential effects of mucins interacting with selectins, cytokines, and monocytes. But as I mentioned, a lot of the focus nowadays, at least mechanistically, really is focused around tissue factor and potentially the role of tissue factor microparticles in terms of inducing a procoagulant state. So what are microparticles? They're membrane elements first described as platelet dust based on their appearance on electron microscopy way back in the 60s. Generally, vesicular membrane structures less than a micron in size. And so colleagues that I work with at Beth Israel, Jeff Zwicker and Bruce Fury's lab have put forward the hypothesis that tissue factor-bearing microparticles play a role in cancer-associated thrombosis. And I'd like to present a little bit from their work. This is actually a Dutch study looking with a tissue factor activity assay, looking at tissue factor procoagulant activity across a range of different cancers: pancreatic cancer on the far right, healthy individuals on the far left. And you can see that the pancreatic cancer patients disproportionately seem to express high levels of tissue factor in their blood. Now we're looking at circulating tissue factor in their blood, but it's seen in a couple of other patients and infrequently seen in normal people. So I don't want to go into the details of all the different ways you can measure or look at tissue factor activity. Jeff and the Furys have developed a very sensitive flow cytometric assay using impedance-based flow cytometry to look at tissue factor microparticles, which potentially might be more sensitive than typical flow cytometric assays. And using this particular tissue factor-based flow cytometric assay, they embarked on a series of studies in patients with cancer. And the initial screen is first just to look at patients with various tumor types to see what the frequency of elevated tissue factor microparticles was in their blood. And what you see, of course, you have to characterize healthy individuals. And not everybody who's healthy is completely normal. You do see a few people who had elevated levels, but most of the healthy people had undetectable levels even in this very sensitive assay. So, a few more with non-small cell lung cancer, and the pancreas cancer patients, as you might predict, seem to be overrepresented in terms of the number of people who had elevations in this cross-sectional study. So from that initial study, then they went on to do a case control study looking at cancer patients with acute venous thromboembolism. The question, of course, is if you're going to go into then people who actually have symptomatic thrombosis, you want to make sure that, that not the thrombosis process itself leads to elevations in levels apart from the cancer issue. So we did a case control study of people with any malignancy and obtained samples within 72 hours of the diagnosis of symptomatic VTE and matched these controls for age, stage, sex, and diagnosis. And you can see that the cancer patients with VTE were about 4 times more likely to have elevated tissue factor microparticles than the controls. And finally, in the cancer-associated VTE, the elevations were much more frequently found than people with idiopathic VTE without cancer, so it's not just solely a function of having venous thrombosis itself. So following that, then, the question, of course, is can you use this biomarker in a way to really identify higher risk people to actually prophylax them? So Jeff embarked on a study, a randomized phase 2 study to evaluate the role of primary thromboprophylaxis in cancer patients, a study called the Microtech study, microparticles thromboembolism and enoxaparin cancer study, asking the question, do elevated tissue factor microparticles predict thrombosis, and can this increased risk be safely prevented with prophylactic doses of low-molecular heparin? It was a study funded by Sanofi, who provided also the enoxaparin. And the design of the study really involved getting cancer patients starting on chemotherapy of 3 different tumor types, lung, gastrointestinal, I think ovarian was also included, and then measuring their microparticles before. And the people with high levels of microparticles were randomized to either enoxaparin, 40 milligrams once a day. Actually, the treatment period was initially 180 days, was shortened to 3 months, or observation. The group with low microparticles were just left on observation. They were not prophylaxed. Actually, even though it involved injections, there was blinding with respect to who got it, because in fact there were 2 observation arms, so you wouldn't know whether they were low or high microparticles if they were being observed. But the data then I'll show here were the inclusion, pancreatic, non-small cell lung, and colon were actually the tumor types later expanded to ovarian, but these obviously are more frequent tumor types. First or second line therapy, you want to get people at a relatively uniform point in their course. The ECOG performance less than equal to 2, and they excluded higher risk people with VTE, coagulopathies, and they had to have obviously preserved organ function, particularly renal function, since they were potentially going to get enoxaparin. The primary endpoints were symptomatic VTE, and there was also ultrasound screening of these people at several points during treatment to see whether they had asymptomatic clots in particularly their lower extremities. The secondary endpoints were survival bleeding or all venous arterial thrombosis. The study actually initially was targeted to get 200 patients for various reasons. It only accrued 70, which led to less power in terms of the actual conclusions. But what Jeff was able to show actually in the group that had the high tissue factor microparticles a suggestion that there was a significant reduction, a suggestion, I don't say significant because the p-value is 0.06, but there was a reduction from 27 to 5%. But again, it didn't reach, didn't have as many patients as he'd hoped for reasons I won't bore you with. So anyway, there was no difference in bleeding, and actually, if you go back, the low microparticle group had the same rate as the enoxaparin, suggesting that the microparticles might be a promising assay of tissue factor, a promising way to add to some of the other predictive models for identifying high-risk patients potentially who would warrant prophylaxis. Finally, where is all of this field moving on a mechanistic basis? And issues of tissue factor biology? It turns out, and this has been known for a while, but the mechanism has only really been worked out in the last few years, there's actually a latent form and an active form of tissue factor. And a critical player in this is an enzyme, protein disulfide isomerase, which basically causes a change in disulfide, a reduction, so that change in the disulfide, removing the hydrogens and causing a covalent bonding between these two disulfides to render a more active form of tissue factor that might be more active in procoagulant activity. And so Jeff and the Furies are actually have approaches and have developed small molecules actually to target potentially this protein disulfide isomerase as a novel antithrombotic approach. And by doing a screen, they actually found some natural supplements, isoquercetins, which can actually inhibit this enzyme. They're pursuing this as a potential therapeutic strategy that hopefully might be devoid of any hemorrhagic effects like an anticoagulant. So this is an active area of investigation in terms of a novel antithrombotic approach. So let me just finish up on the last potential issue. I think many of you are aware of prior studies suggesting that low molecular heparin actually prolonged survival in patients with cancer in the absence of prior VTE. A lot of this came out of some of the early studies with low molecular heparin, that there might be some benefit in terms of heparins and some kind of anti-proliferative or anti-metastatic effect. The methodology in some of these studies, some of it came from retrospective cohorts. There were small signals, but they're, really, when you looked at the data, they methodologically, the studies had enormous problems in terms of looking at that. So a few years ago, Harry Buehler, one of the leaders in the thrombosis clinical trials area, actually mounted a study. I don't believe it's been published. It was presented at the thrombosis meeting a few years ago. It was called the IMPACT trial, effective low molecular heparin to drop around survival in patients with cancer. And this was a multi-center randomized open label trial in 500 patients, 73 centers in 10 countries, where they included patients with hormone refractory prostate cancer within 6 months of diagnosis, about 40% locally advanced pancreatic cancer within 3 months of diagnosis, about 26% in stage 3B lung cancer. Because one of the issues in some of those trials, if you look, they're very heterogeneous cancer patients taken at different times in their course, which obviously could lead to all kinds of methodological issues in trying to figure out. They administered nidropyrin once daily at therapeutic doses times 2 weeks, followed by half therapeutic doses for 4 weeks, and then 6 cycles. Kind of make it like cycles of chemotherapy, which was the rationale, rather than just a short period, a more sustained issue if you're arguing for a metastatic effect. Their primary and secondary efficacy outcomes were death due to all causes, and the time to cancer progression. Overall death rate was very high, 56.1%. Median survival was no different in the people getting nidropyrin or controls. The survival difference didn't vary over time. The bleeding wasn't an issue. In a subset analysis, there was a small trend towards better survival. Now, I know talking to colleagues that this trial, despite the deliberate way in which it was designed, and the restriction in summertime was criticized due to marked underpowering in terms of any type of effect they were trying to look at. But I just wanted to illustrate this is an area, I think, where there was some hints of a signal, but people trying to really sort it out have not been successful in really showing that low molecular heparins really, at this point, improve survival. So I think at this point I'll stop. I do want to really thank my colleagues really for the investigational work I presented on tissue factor microparticles, Jeff Zwicker, Bruce and Barbara Fury. Jeff's really been the leader. I collaborated at the VA in participating in the microtech study, as well as several other centers did as well. Thanks very much.